Welcome. I'm Carolee Lee, founder and CEO of WHAM, Women's Health Access Matters. On behalf of WHAM and our partner, the American Heart Association, thank you for joining us today for what promises to be a fascinating discussion with the foremost leaders in women's heart health. We will also be joined later in the program by Kalisha DeSource-Figures, Special Assistant to the President for Gender Policy at the White House, and we thank her for joining us. In 1993, Dr. Nanette Wenger's seminal paper shook the medical community by highlighting the striking differences in women's heart disease risks, prognosis, treatment, and outcomes. Nearly 30 years later, heart disease is still the #1 killer of women. Dr. Wenger is going to join us in this dialogue, and I want to all ask you to think about how revolutionary and bold it was for her to ask in 1993, does sex matter? The answer, it turns out, was yes, and that changed science and showed how heart disease was different in women, and it has saved thousands of lives. Earlier this year, I called Nanette to share the new WHAM report data with her, only to hear her say she couldn't speak for very long because she had patients waiting. Still seeing patients at 92, Nanette, you are amazing. Nanette has never stopped fighting for women's health, yet 30 years later, we still have some of the same challenges. But we also have some new perspectives. We have some data focused on the differences in women's heart health, but not enough. And now with the WHAM report, we have new data showing the economic imperative for driving change. Perhaps this will offer a new lens through which to look at these issues. We also can't talk about leadership in heart disease without talking about the American Heart Association and its CEO, Nancy Brown. Under Nancy's leadership, AHA has become a global authority on heart health, a determined advocate for equitable health, and a relentless force for innovation. And now, please let me introduce Nancy Brown, CEO of the American Heart Association, and thank you, Nancy, for all of your support.
Hello, I'm Nancy Brown, Chief Executive Officer of the American Heart Association. Thank you for joining us during Heart Month. Today's conversation is about improving women's heart health from overcoming disparities to enhancing economic opportunities. I'd like to thank Carolee Lee, CEO and Chair of Women's Health Access Matters, otherwise known as WHAM. Carolee is a fierce advocate in advancing women's health. She had a vision to evolve the conversation around women's health, and did just that through the WHAM report by bringing together leaders in business, science, and medicine, public health, and more. The WHAM report asks a very important question. What does society stand to gain when we invest in research focused on women? And the data is dramatic, showing that increasing investments in women's heart research will drive better health and better economic results. This work is a direct result of Carolee's commitment to realizing that vision. I'd also like to thank the panelists, including our own Dr. Jennifer Hall, American Heart Association's Chief of Data Science and Analytics, and treasured AHA volunteers Dr. Stacy Rosen, Dr. Annabelle Vogtman, and Dr. Chloe Bird. Today, they will share their thought leadership on the importance of investing in women's health. I am also incredibly honored to introduce Dr. Nanette Wenger, a pioneer in the field of women's cardiovascular research and care. I'm privileged to call Dr. Wenger a friend and a colleague. Her contributions to our understanding of women's heart health are immeasurable. Her influence has resulted in lives saved and more women working in science and medicine. Cardiovascular disease is the #1 killer of women, claiming more lives than all forms of cancer combined. In fact, each year, heart disease and stroke take the lives of 1 in 3 women we know and love. Women comprise over 51% of the U.S. population and yet continue to be underrepresented, undertreated, and underdiagnosed for cardiovascular disease. We are beginning to understand the economic benefit of prevention. Cardiovascular diseases cost our economy close to $400 billion annually in direct costs, lost productivity, and mortality. This is one of many reasons the insights from the novel WHAM report, for which the American Heart Association is also a contributor, are so compelling. It illustrates how our society and economy could benefit by increasing investments in women's health research. The American Heart Association and Go Red for Women are committed to helping women take charge of their health in every stage of life. We're proud to collaborate with organizations like WHAM to elevate the real issues facing women and removing the barriers that prevent more women from living longer, healthier lives. Thank you again to Carolee and WHAM for your collaboration, to our speakers, and to all of you for joining us as we shine a spotlight on women's heart health.
Thank you so much, Nancy, for your incredible support of WHAM, for your partnership, and for your leadership. WHAM's success will depend on the collaboration and partnership of the American Heart Association and new synergies within all the ecosystems which we will touch. As the founder and CEO of an international brand, women were at the heart of my company, both as customers and employees, 85% of which were women. As an entrepreneur who started at my kitchen table and grew, built, and led a global company and eventually successfully sold it, I can tell you from experience, women's health is an economic issue we can't afford to ignore. Let me frame our discussion today with some key data points. Women are the majority of the US population, nearly 50% of the workforce, and control over 60% of personal wealth. In the US, women are responsible for over 85% of consumer spending. That's more than $11 trillion. Women make over 80% of healthcare decisions. Now think about the data I just outlined for you. Women drive the economy. Yet women are an understudied species and continue to be underrepresented in vital health research. The NIH only began to ensure the inclusion of women in clinical research after an act of Congress in 1993. And it was only in 2016 that the NIH began requiring studies to use female mice in animal cells. The impact is far-reaching. It means when it comes to keeping our economy healthy, we're often using analysis and data that doesn't even apply to half the population, the driving force and engines of the global economy. We know that sex and gender-based health differences and disparities exist. Women are 2/3 of all patients with Alzheimer's disease, and not just because we live longer. Women are 80% of all patients with autoimmune conditions, and 50% more likely to die within the year following a heart attack than men. And it's striking to note that heart disease remains the #1 killer of women. Heart disease and stroke cause 1 in 3 deaths among women each year and kill more women than all cancers combined, as Nancy said. Doctors and patients often miss signs of women's heart disease, leading to poor diagnosis and outcomes, and only 38% of participants in cardiovascular trials are women. In my experience in the C-suite and the boardroom, change starts with data. It became apparent to me that we lacked the data about the economic costs, benefits, and social impacts of attention to sex and gender in health research. In 2018, I shared this data with a group of businesswomen who were motivated to build the business case for funding research focused on women, and we created WHAM, Women's Health Access Matters, a nonprofit, nonpartisan organization working to increase awareness of and accelerating funding for women's health research. We commissioned the RAND Corporation to create a study on the economic impacts of accelerating health research and investment in women. The WHAM report, the Case to Fund Women's Health Research, and Economic and Societal Impact Analysis, is really the first rigorous data-driven study to measure the economic opportunity and impacts for funding research that specifically focuses on the health of women. We chose 4 areas to study which we knew disproportionately, exclusively, or differentially affected women: brain health, autoimmune immune disease, cardiovascular disease, and cancer. The reports confirmed disparities in funding for women's health research and showed that only 12% of Alzheimer's research dollars are allocated to projects focused on specifically on women, 7% of autoimmune rheumatoid arthritis research, and 4.5% of coronary artery disease research. But here's the good news. It turns out that women's health research isn't just good science, it's a good investment and yields higher returns than general research. For coronary artery disease, the most common type of heart disease, the WHAM report shows that if we doubled that 4.5%, adding just $20 million, we would get back nearly $2 million to our economy. If we implemented the findings in the WHAM report together, we would invest a little over $300 million and get back over $13 billion through greater quality of life, workforce and economic gains, and reduced healthcare costs. Adding research for each of these disease areas is important because while research can seem siloed, we know that these diseases are actually interconnected, that improving heart health can also improve brain health and more. That makes the imperative for investing in women's health research even stronger. As businesswomen, we keep asking ourselves, how can we continue to make decisions based on information that excludes 50% of our population, more than half of our workforce, 60% of our wealth holders, and 85% of our spenders? We can't, and we shouldn't. No CEO looking at this data could argue to blindly continue with the status quo because no business could afford it, nor can we as morally and ethically responsible individuals turn away from these facts. The WHAM report shows us clearly that this is not just about women. Everyone benefits. Sex and gender research is the gateway to the future of precision medicine. We are grateful to the RAND Corporation for their profound findings. We're joined today by a panel of incredible leaders in women's heart health. And as we move forward, please put any questions into the Q&A section, and we will leave time at the end for those questions. As I mentioned earlier, Dr. Wenger released her seminal paper in 1993, Cardiovascular Health and Disease in Women. Thank you, Nanette, for your extraordinary leadership and for your participation today.
Hello, everyone, and let me share with you how excited I am at this webinar and at the sharing of information about women's heart health. We all know that this is the major cause of death in women. Yet let's look at our retrospectroscope and realize that in the last century, cardiovascular disease was considered a disease of men, even though more women were dying annually from cardiovascular disease. And therefore, the research was focused on men. As a matter of fact, even a select group. It was middle-aged Caucasian men who were studied. And the results were considered to be able to be extrapolated to the total population. The concept of sex differences really had not been explored. And this is an entire area of major research today, not only in the cardiovascular arena, but in many other specialties as well. Let me tell you just a little bit about how some of this came about. I was seeing patients, women, in the coronary care unit, in the clinics, in the laboratories, who had and who were dying from coronary disease. And when I checked the textbooks to find how best to treat these women, what I found was a complete absence of data. And I shared with the NIH and with the professional societies my concern. Finally, we had a workshop on cardiovascular disease in women that the National Heart, Lung, and Blood Institute essentially sponsored. And you know, typically the interval between a workshop and a major conference is a year or two. This was almost a decade. But the workshop that produced this New England Journal of Medicine paper, I think, is a major contributor to women's heart health today, because it was the first time that the term women and coronary disease were coupled in the title of an article in a major journal. Remember, though, we had no data about women, and still women were dying in greater numbers annually than were their male peers. Fast forward to about the year 2000, when we began to see specific sex-based information about prevention, about diagnosis, about testing, about management, and about outcomes for women. And suddenly there was a precipitous decline in cardiovascular mortality for women, so that about 2013, 2014, for the first time since these data were examined, fewer women than men died from heart disease. Now, we are delighted to be in second place and we want to stay there. But I must tell you my concern, and that is in the last few years, we have erased some of the advantages of the past decades for women, in that the decline in mortality among women has plateaued and in some instances has decreased. And particularly, this is relevant to young women. And in young women, we are seeing the epidemic of sedentary lifestyle, of obesity, of diabetes, contributing to their decrease in heart health. I must tell you how important advocacy is, because the National Heart, Lung, and Blood Institute's Heart Health Campaign and the American Heart Association's Go Red campaign increased awareness among women who were essentially unaware of their cardiovascular risk, but awareness that this was the major health problem. But as we examine the data recently, we see that cardiovascular awareness in women has declined abruptly, and particularly so among the most vulnerable populations, women of racial and ethnic minorities. So there is a huge task that we have ahead. And one of the mottos, if you will, that I have shared with my colleagues over time is that if we are to enhance women's heart health, I think there are 4 steps on the journey. Investigate, do the necessary research to give us a scientific database on recognition, prevention, management, outcomes. Educate both women in the community and educate their healthcare providers about risk of cardiovascular disease in women. Third, advocate, as this group is doing and as so many of our associates are doing. And then, if necessary, legislate. And you know that it was the Heart Health Act and the Research for All Act that mandated within the National Institutes of Health the representation of women both in basic research and in clinical research. So I want you to essentially beat the drum for these 4 areas: investigate, educate, advocate, and when needed, legislate. And I expect that this webinar is going to be a wonderful initiation of some advances for the heart health of women worldwide. So thank you, Carol Lee.
Well, thank you, Nanette, for your insights and leadership back in 1993 and throughout your esteemed career, and for your continued energy and drive and friendship, which continues to propel you to new heights, and for your outstanding contributions to the health of all women. We are very grateful to you and honored. I am totally honored to share this dialogue with you. So thank you so much. Let me now introduce our esteemed panelists. Dr. Jennifer Hall is Chief of Data Science at the American Heart Association and is the leading expert at the intersection of health, technology, and science. Thank you, Jen, for being such a great partner to WHAM.
Always happy to collaborate with you and your colleagues.
So, Jen, do you want to talk to us a little bit about how you feel technology has advanced the prevention, diagnosis, and treatment of heart disease?
Would love the opportunity. I think, as we've talked before, certainly just starting with the conversation of cross collaboration. And I think the example of the American Heart Association working with WHAM is a great example of that, having business leaders like yourselves working with leaders in research come together and understand where that cross collaboration can lead to great opportunities for all. You bring your expertise, we bring our expertise, and through that, we think things through much differently. And one of the groundbreaking pieces of that was the WHAM report, bringing research together with an eye towards the business lens. What would it take? And we tend to think as scientists as research in one silo. And that has gotten us in a little bit of a predicament, as you can see. So when you think about research as all-encompassing in terms of the investment and how that affects not only women, but children and their families and the workforce, we see that many people should be at the table and many people should be discussing all of these issues together. But the WHAM report was one of the fundamental pieces that I think brought that to the table. And when you think of data, we know one of the visions of Nancy Brown, I'm so very fortunate to be able to work with her, was when I came in, she said, Jen, we really should have a data marketplace. People keep all their data on their computers and they don't want to share it. And she was ahead of her time. And we built the American Heart Association Precision Medicine Platform with our collaborator, Amazon Web Services. So this allows researchers all over the world to collaborate in real time and bring their data together and share it in real time in a governed way, but in a way that gives access in days, not months or years. And one of the real important pieces of this for women is that, as we've talked about, women are underrepresented. And the data on women is much less than the data on men. And if we pick into that a little farther, the data on underrepresented racial and ethnic minority women is much less. And so you really must bring all these groups together to have enough power to be able to understand what these women really need and what we need to do as next steps in research. And so that is one of the areas where bringing this technology, and what I mean by technology here is really great computational power from the cloud, bringing collaborators together in real time so they can work from around the world, especially during these pandemic times. They can work from home, they can work in their lab, share data, and bring these data sets together. And then secondly, with the leadership of the American Heart Association, and especially Claire Kinsey, who leads our Go Red for Women group, that we've built out a Research Goes Red platform. So women can become enrolled in research, they can answer surveys, and we've understood that individuals and women around the globe are going to be our next set of data, that enrolling them in studies is not the only opportunity anymore. We need to be where they are. We need to join them where they are in their communities, make it more accessible for them, and let them join opportunities that are right for them. Make it much simpler to be engaged in research and make awareness one of the major contributions from the American Heart Association.
Well, thank you, Jen, for these insights. And of course, I look forward to continuing our partnership, and a shout out to Claire for the great work, in fact, that she is doing as well. So much more ahead of us. Dr. Stacy Rosen is a cardiologist and senior vice president at the Katz Institute for Women's Health at Northwell Health, as well as a member of WHAM's collaborative. And she also produced a movie, Ms. Diagnosed, about women's health inequities, which we can talk about as well. But Stacy, perhaps you can share with us how heart disease has changed over the past 30 years since Dr. Wenger launched her seminal report, and what hasn't changed sufficiently that we need to focus more intensely on?
Oh, thank you, Carol. It's a great question. First, I want to thank you and the WHAM group for the extraordinary work you're doing. And for bringing this really esteemed group of, I'll call us advocates as a baseline, approaching, as Jen said, the need to improve the health of women from so many different disciplines. So, I often tell the story. I graduated medical school in 1985, and that was the exact year that the curves for mortality rates for heart disease for men and women crossed. And for the next 20 plus years, more women died every year of a disease that I was taught in medical school and early training was a man's disease, as Nanette implied. In fact, for the first 15 years after I graduated med school, men's mortality rates plummeted, black diamond ski slopes, and women's actually increased, so that the delta was even worse. And this, again, was a disease that we were truly taught was a man's disease. Then, as Dr. Wenger wrote and spoke of in her Herrick's lecture, there were milestones and individuals who would not tolerate this as the status quo. Decade of the 1990s brought us leaders at the NIH, Dr. Healy, Dr. Blumenthal, decided that we needed to look at sex and gender as a critical part of science and the development of medical practice. As Nanette said, the NHLBI had its first conference called CV, Health and Disease in Women. Dr. Wenger, I didn't realize that this was actually one of the first times that women and heart disease were used in such a seminal publication. It seems as that should be hundreds of years ago, rather than just a few decades ago. The next decade brought us information and reports from the Institute of Medicine, AS, now on sex differences in health and human disease and health. The launch of the Women's Heart Study, which studied aspirin, because the physicians' health study decades before only used men. Women guidelines on non-invasive testing in women, first authored by my friend and colleague, Dr. Jennifer Meirez. The launch of the WISE trial that showed us, even down to a cellular level, women's arteries behave differently. Then we go on a next decade and you see more work being done. Prevention guidelines unique for women. The IOM report actually stating in 2011, I believe, that enough work had been done to decrease mortality rates for women with regard to heart disease. And this was important because in this second monograph that was put out by the IOM, heart disease for women was one of the areas in which improvement had been made since the prior decade's publication on Does Sex Matter? And then finally, we had the launch of the critically important Go Red for Women movement. And I think that this movement defined for many of us a new path forward. The critical importance, as Dr. Wenger said, of advancing science that is sex and gender focused. If we don't have the data and we don't have women participating, we can't speak from strength. We wanted to change clinical practice, both by advocating the way women behave in a doctor's office and a clinician's office, but we also needed to advocate for funds, legislative wins. And then the Go Red movement is also commended for appreciating the critical partnership with media to really expand women's awareness. So this, I would say, for me as a clinician, investigator, advocate, was sort of the golden age from what we do. But the last decade, there's been some slippage. Sharon Mulvey, one of our now Canadian cardiology friends, sometimes calls this the lost decade. Ideal cardiovascular health as defined by the AHA is decreasing. We know that awareness is decreasing, and we're learning that more and more the social determinants of health are critical. So a long answer to, we have done so much, but what hasn't changed, Carolee, is the critical need to expand a scientific investment and focus on sex as a biologic variable and the gendered impact on women in regard to cardiovascular disease and health. And it means expanding into translational science, implementation science, population science, even our partners in behavioral economics. Why do people make the decisions that they do? We have to increase the ability and the interest of women to participate in clinical trials. We have to study ways to optimize cardiovascular health throughout a woman's lifetime. And as Dr. Wenger so aptly said, we need to advocate and legislate more because these wins are critical. Not wanting to end on a bad note, I can tell you that despite what some consider the lost decade, we are up for the challenge. So thank you.
Oh, Stacy, thank you so much for the historical perspective. That was really fantastic, and for being such a close ally of WHAM. And we look, of course, very much forward to continuing to partnering with you in the CATS Institute. Dr. Annabelle Santos-Vogelman is the co-founder and medical director of the Rush Heart Center for Women, and just recently joined WHAM's collaborative, which is a group of researchers and clinicians from leading institutions focused on women's health to advance sex and gender research. That WHAM is very focused, obviously, on bringing everyone together. Annabelle, can you please share some insights on the heart centers for women that I know you're very involved in, especially the one you've created at Rush, what you've accomplished and what your plans are for the future?
Thank you so much. Actually, the Heart Center for Women at Rush was inspired by the Go Red for Women movement because we were volunteers for the American Heart Association, and we would be going out there to the communities to educate women about heart disease. And they would ask us, where should we go to get better care for women? And so out of that, Dr. Lynn Brown and I decided to create the Rush Heart Center for Women. Dr. Martha Galati was part of our center in 2003, and she was our research director. And what we wanted to do was basically what Dr. Wenger wanted people to do, which was to investigate, educate, advocate, and legislate. And we wanted to create a center that would not only take care of women, which, by the way, when you take care of women, you take care of the whole family, because the women started bringing their brothers and their husbands. So it's, women, as you said, make a lot of the decision for the family. Well, they definitely make decisions for the health of the family. And when they saw that they were getting great care, they asked, so do you treat men too? And I said, yeah, I have experience with men as well, because we were taught about heart disease in men, mostly in medical school. But we wanted to reach out to the underrepresented minority women. We wanted to educate the women of color. So we would do community programs as part of the Heart Center for Women to teach them about lifestyle changes, how to prevent heart disease, how to take care of yourself when you have heart disease. So we were really educating women as well as doing studies on women. But what we need is funding for heart centers for women, because a lot of heart centers are always under scrutiny by the medical center. Is it making money? Is it cost effective to have this? And if we don't have that funding, like Dr. Noelle Berry-Merce got from Barbara Streisand, who just gave her $5 million, we are under scrutiny, under pressure. And if we had the funding to have time to spend with our patients, to educate them, and to take care of the whole family, we will always be under stress to make more money for the medical center. But if we have that funding to educate and to study women, I think we would be much better off. So we're planning to gather a group of women who have started heart centers for women all over the country to make it a more collaborative and group effort to teach other women how to make a heart center for women more successful in their medical center. So I'm hoping that will help other women who keep calling us to ask us how to create a heart center for women. We need to educate them on how we can do that successfully. So thank you for asking, Carolee Lee. And thank you for having me as part of this WHAM initiative.
Well, first of all, I'm delighted. We go back a number of years when I remember hosting a dinner way long ago in Chicago. And so it is wonderful to reconnect with you. And it's great to hear the extraordinary work you're doing and the idea to continue to grow these centers, which of course is so necessary. So I'm sure you'll succeed, and I'm sure WHAM can be helpful. Dr. Chloe Bird is a senior sociologist at the RAND Corporation and one of the contributors to the WHAM report. So it has been a pleasure to partner with you, Chloe, and with Dr. Lori Frank during the past year and probably year and a half at this point. And if you could please share how you and your peers explored and documented the data that obviously led to the creation of the WHAM report, I'd be very grateful.
Thank you. Let me screen share this. And I'll go through some slides quickly here on the work. Here we go. So I just want to acknowledge my colleagues for this work on the societal impact of increased research funding for women's cardiovascular health. And as everyone here is aware, this work was commissioned by the Women's Health Access Matters group. A question we're familiar with now. Why don't studies include more women? Remarkably, a study of women's inclusion in clinical trials found that less than 50% of clinical trial participants through 2015 were women. And perhaps more importantly, even among studies with data on both men and women, it remained uncommon to analyze that data by sex and gender, to even begin to understand what is the evidence of how things operate differently, despite the fact that we know that differences go down to the cellular level, as well as the social differences. Now, this discrepancy has real world impacts. Women are more likely to die within 1 year of a heart attack than are men, and they're also less likely to receive surgery for an acute MI and receive revascularization. Women's Health Access Matters came to us to look at the impact, the cost of this, these gaps across 4 diseases. In each case, we looked at what's the metric. Well, we took what's the NIH been spending on women's health, and what would, as a yardstick, doubling that amount, and the impact over 30 years, assuming it takes 10 years to get a benefit from the science. This is informed by some of the work of our RAND colleagues in Europe, and just playing it out over 30 years. So this is based on a 1-year investment. Not that that's the max we would recommend, but that it gives us a measure. We looked at health improvements, and here we're assuming tiny improvements because we want to show whether or not, even with very, very conservative assumptions, is a positive return on investment. We looked at a 0.1% improvement in what I'm presenting today, 1/100% improvement carried out over those 30 years, in decreased age incidence of coronary artery disease, a slowed rate of disease progression, so people spend slightly longer at less severe stages, and this is based on innovations that are already in the pipeline and the kinds of innovations we could expect from further research, as well as improvements in health-related quality of life over the time frame. We also assumed that this work would have some benefit to men, just as women have received some benefit from the gender blind, meaning women are kind of left out, research. We assume a 3-to-1 return, that there would be a much larger return to women, but men will also benefit from things we don't know about health. Now, when we take those 3 types of improvements from research, we see these impacts and outcomes. Longer lives, fewer years living with coronary artery disease, a reduction in lost years of quality life, and fewer lost years of productivity for patients and for their caregivers. And in addition to these benefits, there's an impact on cost with fewer nursing home years and other healthcare costs. In order to not build in inequity, as you're all aware, this is for informal caregivers, it's actually for patients' earnings as well. Women earn less than men in this country, and we all earn less than white men on average in this country. So a point that we made a decision on early in the model was to use white male wages across all of the models, so as not to devalue women's lives for being women who get paid less, and to not devalue caregivers. We also don't assume that the current level of inequity would continue over 30 years. So we'd like to look optimistically. So that's one piece. It turns out not to be a very expensive part of it, but it's relevant to the equity issue. Now, how do the results play out? Here you see in green are the benefits to women, in blue to men, and we have a savings in life years. We have a reduction in cardiovascular disease years living with cardiovascular disease. There are smaller reductions in lost productivity to self, the patients themselves. It actually increases caregiving slightly because if you live longer, then you are likely to at some point need caregivers. So it shifts, but it's still there. And that's mainly for women because women would be living longer. And we have this very large gaining in what would have been lost year, quality adjusted life years. When we look at that in terms of cost, the biggest savings come from that reduction in low quality years of life, followed by the productivity, the labor force data. But as you can see, that's not driving this. That's a much smaller piece of the big picture. So out of what we were astounded to find, only 4.5% of the fiscal year 2019 NIH budget had gone to research that explicitly said they were going to look at women's health. That's only $20 million. Now, it's possible that there's more work that intended to do that, but we're certainly not seeing it published in the literature. It is truly a drop in the bucket in the NIH coronary artery disease budget. We found, based on these models, based on data on the actual healthcare needs and expenses in the US population as a whole for women and for men, a 9,500% return on investment, a $1.9 billion impact. Now, we would be excited with a program, the hands-on program, a social intervention that has a 200% return on investment that pays for itself. This reflects the price, the inefficient science. It reflects the cost of what we don't know, the cost of what we do wrong because we don't know how to treat women's health properly. And this is based on not on a 1% or a 5% improvement, but a 0.1% improvement in the outcomes. This presents a large cost savings because it can result in reduced government spending. It results in reduced out-of-pocket expenses. We also found the large return on investment it's so striking that we were set back looking at the extent to which the US is underinvested in science as a whole. When you can see very large returns on investment, we are leaving money on the table. It is costing tremendously because of what we do wrong, because of what we don't know. And our model approach can aid with decision-making for funders, by business leaders, the payers, and support efficient resource allocation. And included that is the consequences of innovation that will need to be assessed proactively and ideally coupled with policy innovation. We'll also see caregiver and patient increases in productivity. Now, these research investments on women can have life-changing effects on our society, lowering the prevalence of coronary artery disease, lengthening patients' lives, improving the years of those, the quality of the years added, and reducing healthcare costs.
Excuse me, Chloe, I'm going to interrupt you only for a minute. I'm so sorry because our next guest has to go back to the White House or go back.
All right. Well, thank you.
Thank you. And I'm going to come back to you in a minute. Kalisha, I know you have a hard stop, so I've introduced you at the beginning. So thank you so much for joining us.
Thank you. And thank you all so much for just accommodating. Sorry to have interrupted. Very excited to be here and sorry to have to leave so soon. Thank you, Carolee, for inviting me here today. And thank you to Nancy Brown and Dr. Nanette Wenger, Jen Hall, Dr. Rosen, and Dr. Volgman. This is an important discussion, and you all are doing just such important work, leading the fight against heart disease and more broadly advocating for women's health. My name is Kalisha De Jesus Figures. I serve as Special Assistant to the President for Gender Policy here at the White House Gender Policy Council, where I work on a range of different issues and where I help lead our national strategy to advance gender equity and equality. And just to give a little bit of background on the Gender Policy Council, it is almost our 1-year anniversary. The president signed an executive order on International Women's Day last year, establishing the Gender Policy Council to ensure that there was a whole of government approach to advancing gender equity and equality, not only here in the US, but also globally. Just last fall in October, we released the first ever US government strategy to advance gender equity and equality. And that strategy is clear. Gender equality is not only fundamental to every individual's health, safety, and ability to exercise their basic rights. It's also essential to economic growth. In the strategy, we outlined 10 strategic priorities, and we recognize that these 10 priorities are deeply interconnected. The education of girls affects their future economic security and that of our nation. Gender-based violence, including sexual harassment and abuse, hampers economic and political participation and influences the health and well-being of survivors. Restrictions on access to healthcare and health disparities undermine women's ability to take care of their families, advance in the workplace, and lead in all sectors. So it's thrilling to see this convening. It's thrilling to see what was outlined in the WHAM report. It's a powerful example of how women's health and our economy are inextricably linked, showing that investing in women's health research has huge economic impacts. That data is critical for developing and advancing policies and for driving change. So thank you all for the work that you've put into it. We are all here together going into year 3 of a pandemic. It's a pandemic that has fueled a health crisis, an economic crisis, a caregiving crisis that have magnified the challenges that women and girls, particularly women and girls of color, have long faced. And so I want to take just a little bit of time to sort of dive into at least some of the our vision, right, for better women's health, for better health for women and girls across the country that we outlined in the strategy. So we included everything from working to ensure equitable access to high quality, affordable healthcare for women and girls and their families, promoting access to reproductive health, closing disparities in maternal health care, and reducing maternal mortality, particularly for Black and Indigenous women who remain 2 to 3 times more likely to die from pregnancy-related complications than non-Hispanic white women, regardless of education level. It included addressing systemic bias and racism in healthcare provision, including robust implementation of Section 1557 of the ACA, which prohibits discrimination on the basis of sex, race, national origin, disability, and age. We know that the mental health consequences of the COVID-19 pandemic have also exacerbated pre-existing disparities, particularly for girls. So providing comprehensive healthcare includes preventative and mental health and treatment services. Our vision is comprehensive care for women and girls because we know that is a baseline pillar for their ability to thrive. And so we need to reduce health disparities in research, prevention, and treatment of diseases historically associated with women. That's breast cancer and cervical cancer. And the reason why this convening is so important is because it also includes leading causes of death for women that so often go unseen, like heart disease and like stroke. We're committed to investing in research that explores the specific needs of women of color and the social determinants of health that often contribute to racial, ethnic, and other disparities, such as those that make Black women disproportionately impacted by uterine fibroids, more likely to die of breast cancer, more susceptible to heart disease, and more likely to be diagnosed with HIV. So that's just a broad overview, and that's just one of the 10 pillars included in the strategy. And I say that to say, the strategy is a tall order, right? We have a lot of work to do, particularly in this moment, to advance gender equity and equality and to close the health disparities that have long persisted, right, for women and for girls. And so deeply grateful for the partners that we have because we cannot do this work alone. We need robust research. We need strong partnerships. We need deep investments in order to really make progress. So thank you all for having me. I'm so sorry that I have to jump off, and I'm just grateful for the work that you each are doing.
Well, Kalisha, I'll just very quickly thank you and say I'm so appreciative of everything you're doing, obviously of your high energy level, but also recognizing that women's health is definitely an economic imperative. And hopefully the WHAM report will help you be able to use it as a catalyst for change. And
absolutely
look forward to partnering with you. Thank you.
Absolutely. Thank you.
Let me at this moment say thank you to all of you so much for joining us today. And thank you again to our wonderful partner, Nancy Brown and the American Heart Association, to our honored guest, Dr. Nanette Wenger, and to Dr. Berg, Dr. Hall, Dr. Rosen, Dr. Santos-Fogelman, and Kalisha Figueres for such an informative and rigorous discussion that really brings the imperative for women's health research to life. We created the WHAM report to drive change, and it's thrilling to hear from our partners and the leading cardiologists, researchers, and change makers about how they are going to use this data to transform thinking and actions. And we're only at the beginning of how the WHAM report will create extensive and innovative change, and hopefully create strategies to achieve innovative alliances, policy change, and economic impact. We invite all of our guests to use this data. You can find the details on thewhamreport.org. Please join us in this movement. Please visit thewhamreport.org, or you can reach us at info@whamnow.org and follow us on social media. Thank you to my wonderful panelists and to all of you who have attended today. It's so wonderful that you joined us.